Yeah. How old's your son?
5.
Actually, little kid's also like it might be a little over that person's head, but there's nothing like 5-year-old.
Is it out? Is it actually
Or
out?
what's that going to be like? What level is that going to be
It
at?
depends on the city. I think
We are live. We are live from YouTube Live. We are live on YouTube Live.
Perfect. Well, congratulations.
One minute left.
Yeah.
Yeah. How old's your son?
We're broadcasting in 5, 4, 3, 2.
Good evening, everybody. Jacques Morcos here. It's my pleasure to continue our Thursday weekly seminars in cerebrovascular and skull base. This is now our 15th session, today, August 27th. I'm co-director of this course and director of cerebrovascular surgery and skull base surgery at University of Miami. The co-directors of the course are and have been Carolina Benjamin, assistant professor, director of Kane's Lab, specializing in brain tumor and skull-based surgery, as well as my partner Mike Ivan, assistant professor, director of research of the Brain Tumor Initiative, specializing in brain tumor, skull-based and epilepsy surgery, as well as my two endovascular and open vascular colleagues, Bobby Stark and Eric Peterson. This is the first time I am not personally in Miami. I'm on vacation in California and my internet connection is so-so. So if I lose you during the broadcast, hopefully Mike Ivan could also take over. I can see some problem with my internet, but Those of you who know Miami, know our center. We have two main hospitals, UMH and JMH. We started this back on May 21. This is a link to view all previously recorded sessions and to see what is coming up. We are here today. There are a couple more coming, and we're preparing to take us probably till the end of December. And I'll be sending out the program hopefully in a few days. If you have questions to our speakers and panelists, please use the Q&A box to send your questions. We will address them at the end. We don't offer CMEs. And please let your friends and colleagues know on social media if you like our programs. And please send me any suggestions for topics in cerebrovascular and skull base topics and specific speakers you would like to hear from. And I'm happy to entertain with my co-directors your suggestions. My email is there, my Twitter account is there. Next week, to give you again an idea what's coming next week, it's a great panel with Paulo Cadri from Brazil on brainstem topographic nuclei and fiber tract anatomy, along with Kazuhiro Hongo from Japan, who will talk about brainstem microsurgery for cavernomas, with our wonderful panelists, Peter Nakaji, Nick Bambakidis, and Oliver Bozinov. Oliver will be beaming in from Switzerland. On every Wednesday, as you also probably know, Mike Ivan, my partner, who actually started with the idea to begin with, has a very nice and successful Miami Global Brain Tumor Symposium. He started back in April. And next week, we have Marcos Maldown, also from Sao Paulo, who will talk about management of brain metastases. Again, same time, 5 p.m. Eastern. Please don't miss that either. Many thanks go to the team that makes it happen here for our webinars, Ingrid, Roberto, Cristina, and Ignacio, who's actually running physically this webinar every week. Here are the links if you're interested, emails, Twitter accounts, departmental Instagram, departmental Twitter account, as I mentioned. Let me introduce our panelists today. First, Albert Kim, Associate Professor of Neurosurgery at WashU in St. Louis. Albert was our fellow here, University of Miami, in skull base and cerebrovascular several years ago, and it was very easy to recognize a star before he even started, and he has been tremendous and continues to be a tremendous force as a surgeon scientist, and I couldn't be any prouder for having a tiny bit to do with his training. And Albert, thanks for joining us. He may have to leave us early. I don't know, he may have a case. And I'm hoping, Albert, you will tell the audience about your new PBS show that I am sure is competing fiercely with the Lenox Hill neurosurgical PBS show, but please, I mean, on Netflix, but please tell us a word about to the audience when you have the microphone later. Jim Liu, Associate Professor of Neurosurgery at Rutgers, New Jersey Medical School. Jim is a tremendous force, particularly in skull base, but also in open vascular surgery. He's editor of the one fantastic video journal for skull base. Jim is equally facile with open vascular and endonasal and open skull base surgery, has been prolific academically, and has also fantastic surgical videos to show us. And Jim, thank you for joining us. And last but not least, Pablo Recinos, Associate Professor of Neurosurgery at the Cleveland Clinic. I've known now Pablo for several years. I've always been impressed by what he's doing, his clinical and scientific productivity, and particularly his presentations. Pablo, thank you for joining us. On to the first of our two speakers, Franco Di Monte. Franco is Professor and Vice Chair of Neurosurgery, University of Texas, MD Anderson Cancer Center in Houston. Franco is Canadian-born. He did his MD and residency at the University of Western Ontario in London, Canada. You can see a picture of it at the top left. Did his residency and then fellowship at Loyola University. I'm sorry, this is a typo. This it's not Gainesville, but fellowship Loyola University with Sam Al-Mafti in '92. Then was the first faculty recruit of another pioneer, Ray Sawaya, when he started the new department of neurosurgery at MD Anderson. And Ray couldn't be prouder from recruiting Franco, and for good reason. Of course, this is decades ago, and since then Franco has gone to do tremendous work and has been, of course, a past president of North American Skull-Base Society. He's professor of the department of also head and neck surgery, and has had a fantastic collaboration with Ihab Hanna from ENT, and they are one of the earliest fantastic teamwork models. You can see a picture of Ihab on the right. You can see a picture of Sam Al-Mafti, who has been a tremendous mentor for Franco. And of course, Franco has some of the largest series of cancer, particularly of the anterior skull base, which is why he's the ideal person to talk about the topic today. Second speaker Suzuka will go first, but Suzuka Sarji. Suzuka is MD, MPH, and I congratulate him this year for becoming professor. He is also residency program director of the Department of ENT here at the University of Miami. Zuka shares heritage with me, as we both Lebanese in origin. He did his MD at St. Joseph University of Beirut, Lebanon in 2000, did his residency in ENT at the same place at a hospital called Hotel Dieu, did his fellowship here in Miami, 2 fellowships, rhinology in 2006 with Roy Cassiano, and head and neck surgery, open head and neck surgery in 2008 with the other head and neck surgeons in the department, did his MPH in 2013. And of course, we work so closely. He works with myself and all my colleague skull-base surgeons in the department. He has a secondary appointment in our department for the last 4 years, has been very involved in the various societies, including NASBS, where he's been SBS chair, and multiple ENT societies you see listed there. He's an educator by excellence. Our neurosurgical residents probably prefer him over the rest of us neurosurgeons and have awarded him the Neurosurgery Residence Teaching Award. And of course, he's facile in both rhinology, open head and neck surgery, and microvascular reconstruction. So again, he's going to give us the rhinologist perspective of anterior sinonasal cancers. So Zuka, with no further ado, I think you should go first. I stopped sharing my slides and I invite you to unmute your microphone, share your slides, and go to it.
Can you see my slides?
Not yet. Did you click on the green share screen button?
It says it failed to start.
Iggy, can you help out? Since when we tested it, it worked.
Yeah, here you go. Here you go.
Perfect.
Yep, we can see it.
Perfect. Can you hear me well?
Loud and clear.
Perfect. Dr. Morkos, Dr. Ivan, thank you for inviting me. It's a pleasure and an honor to be here with you today. Good afternoon from Miami. Good evening for some other parts of the world. Hopefully not good morning, but if you're waking up early, thank you for being here. I have nothing to disclose financially related to this talk, but I have a couple of professional society announcements I would like to make. If you are interested in skull-base surgery, please join us for the annual meeting of the North American Skull-Base Society in Atlanta in February 2021. This is by far the best forum for skull-base surgeons for multidisciplinary collaboration. If you're also interested in head and neck cancer surgery, our international meeting that was canceled this year because of the ongoing pandemic was moved to July 2021. This is the largest head and neck cancer meeting. It happens once every 4 years, and it is the best collaborative meeting for specialists from around the world dealing with head and neck cancer. I would like to bring to you a perspective of a head and neck surgeon and a rhinologist. I would like to talk about sinonasal cancer, not so much about the surgical aspect exclusively, but more as an overview of the topic, because as skull-based surgeons, we get to collaborate on one small part of sinonasal cancers. I'm going to go through some facts and figures. I would like to review the classification, some new entities, and a refresher about the staging system. I would like to discuss surgical management, just to say where we are doing well, where we are failing, and how we can improve things. I would then talk a little bit about introducing non-surgical treatment modalities as part of management of sinonasal cancer, and then we'll go over some opportunities for improvement. So, according to the American Cancer Society, a rare cancer is a cancer that occurs in less than 15 persons per 100,000 per year. According to the Europeans, it's less than 6 cases per 100,000. If I'm talking to you about rare cancers, it is because sinonasal cancer is one of the listed rare cancers according to the American Cancer Society, with a rate of less than 1 per 100,000 per year. We have about 2,000 cases per year in the United States. The nasal cavity and the maxillary sinus are more frequently involved than the ethmoid, and to a much lesser extent, the frontal and the sphenoid sinuses. Those cancers occur more commonly in elderly patients, with 80% of the patients being over 55 years. Men are affected more than women, and there are some areas in the world, like in Japan and in South Africa, where we have more cases of sinonasal cancer. So first fact, sinonasal cancer is rare. Let's look at the incidence. If we go back 20 years to look at the incidence of respiratory cancers, laryngeal cancer has decreased because of a decline in tobacco use. Oropharyngeal cancer, which is not depicted here, has been on the rise because of increasing incidence of HPV. Cancer of the nose and paranasal sinuses has been stable over the past 20 years with no change in incidence. Looking at large series from the SEER database, the incidence has remained the same between 1973 and 2005. Can you see my arrow on the screen?
Yeah, yes, we can.
For men, there may be a small decreasing trend, whereas for women, the incidence has remained stable. And as mentioned earlier, most patients are over 55 years of age. Men are slightly more affected than women. And we'll talk in a second about the different histologies, the most common sites being the nasal cavity and the maxillary sinus. Looking specifically at squamous cell carcinoma, this is a paper by one of our former two of our former fellows, showing that squamous cell carcinoma within sinonasal cancer has remained stable with a slightly decreasing incidence in men. So the second fact, sinonasal cancer is continuing to occur at the same incidence without any changes for the past 30 years or so. So how is survival for sinonasal cancer? When you present with a localized stage, you have a decent chance of being cured. This being said, most patients present with regional and with distant spread of disease. And that's where survival rate drops. That's where we transition from more likely being cured to more likely not being cured. And because most patients present with regional and distant disease, all stages combined have an overall survival of approximately 58% for sinonasal cancers. Has this changed over the years? If we look at survival between 1973 and 2001, we have not done better over the past 30 years for sinonasal cancer. There's no difference in survival between men and women. There is a lower survival in patients of African American descent in the US, and we do not understand this difference, but this is in line with other disparities in survival of head and neck cancer. How have we done in terms of squamous cell carcinoma? You see 3 superimposed survival curves from the patients who fell within the decade between 80 and 89, between 90 and 99, between 2000 and 2009. And you see that we have not made any improvement in treatment of sinonasal cancer. In the rare cancers, cancer of the nasal cavity falls halfway between the cancers that are most often treated and the cancers that are not. We still have a significant room for improvement of survival of sinonasal cancer. So the third fact, survival is not great and has remained the same for the past 3 decades. So what's unique about sinonasal cancer? Well, this is what's unique about sinonasal cancer. You have a respiratory epithelium, you have a very rich connective tissue, stroma with different types of cells, you have glands, you are close to the neuroectodermal structures. So there are multiple cancers that could arise from this lining and from the sinonasal structures. And if you look at the WHO classification of the sinonasal tumors, despite being rare, there are so many different types of sinonasal tumors that it makes it even harder to come up with treatment recommendations for any given type of sinonasal cancer. According to the NCCN guidelines, if you have sinonasal cancer after a biopsy, the guidelines divide you in lymphoma, sarcoma, mucosal melanoma, and all others. Those are the tumors that we typically do not often treat, and those are the tumors that we most commonly see as surgeons, but you see in this group of surgical patients, there's a large heterogeneous list of different types of cancers. So, to summarize, sinonasal cancer is rare, sinonasal cancer is heterogeneous, the incidence is not increasing, survival is fair to poor, and there is limited scientific rationale and weak clinical evidence supporting treatment guidelines because no one can easily run a prospective randomized clinical trial. So some new emerging entities, the World Health Organization has classified head and neck tumors in 2017 in its new edition. And what was introduced, and that's quite unique to sinonasal cancer, is the importance of molecular pathology. Up until 2017, the diagnosis was mostly based on consensus histopathological opinion with some very limited input. Molecular pathology has been recognized as a very important factor to classify sinonasal cancers. Those are the most common sinonasal cancers, and those are some of the ones we see as surgeons. Squamous cell carcinoma is the most common one, both the keratinizing and the non-keratinizing form, and this is rising in incidence because of HPV, and we'll talk about this in a second. Spindle cell squamous cell carcinoma that looks a little bit more like sarcoma, lymphoepithelial carcinoma that looks a little bit more like nasopharyngeal cancer, and then SNUC and SNEC, sinonasal undifferentiated carcinoma, and neuroendocrine carcinomas, which are quite aggressive and which have significant intracranial involvement in most cases and where we fail the most. This is a new entity that was described and recognized as such. And then we have the adenocarcinomas, the intestinal type and the non-intestinal type, both high grade and low grade. So as I mentioned, squamous cell carcinoma, the most common form, the keratinizing squamous cell carcinoma that looks like any other squamous cell carcinoma, mostly related to smoking and drinking. The non-keratinizing, where we are starting to recognize an emerging role for human papillomavirus. A new entity within the squamous cell carcinoma is a cancer that we used to think was adenoid cystic carcinoma, which comes from the minor salivary gland. but turns out to be a unique form of HPV-related cancer. And this will change the way we think about this cancer, because those cancers are usually very radiosensitive and respond very well to chemotherapy. They have a tendency to involve the orbit and the skull base. So that may be an area where non-surgical treatment could make strides. The importance of this entity is because until this entity was described, adenoid cystic carcinoma of the sinonasal cavity seemed to behave slightly better than adenoid cystic carcinoma elsewhere. And this is a big landmark paper from the MD Anderson group, published in Cancer in 2007, that concluded that adenoid cystic carcinoma of the sinonasal cavity tends to do better than other sites of adenoid cystic carcinoma. However, the entity of HPV-related cancer that looks like adenoid cystic carcinoma had not been described. So should we start revisiting some of the literature we know on adenoid cystic carcinoma of the nose? This question still needs to be answered. The not midline carcinoma is a very aggressive form of cancer that tends to affect young patients. I shared a case with Dr. Morkos 2 years ago of a 15-year-old who came to see us with a very aggressive form of cancer with significant intracranial involvement. Had we not recognized that this was the nuclear protein in testis mutated carcinoma, which we call not midline carcinoma, we wouldn't have treated the patient the way we did, which was treating her with chemotherapy according to the sarcoma protocol. She had an excellent response. We operated on her. We gave her chemoradiation. I last heard about her 24 months after treatment, and she was still without evidence of disease. Had we not recognized this entity, she would have been deemed unresectable and would have probably died if we had treated her using the standard non-surgical treatment for sinonasal carcinoma. Sinonasal undifferentiated carcinoma is a very challenging entity because it often presents at very advanced disease. Patients have no symptoms until the tumor is invading their frontal lobe. Within this entity, we have started using induction chemotherapy, and there is some data from MD Anderson. I have a few slides, and I'm sure Dr. De Monte will talk about this, but we are recognizing some entities within sinonasal undifferentiated carcinoma with a particular deficiency that's called SMARCB1 protein, and this is a subgroup of patients that behave in a very poor fashion. We have the neuroendocrine cancers, and similar to other neuroendocrine cancers in the body, those are very chemosensitive. Those tend to present with metastatic disease. I'm putting all this list, including adenocarcinoma, including sinonasal sarcoma, to emphasize the importance of proper diagnosis and proper classification of sinonasal tumors, as this will dictate whether or not those patients would benefit from surgery or whether we are more likely to hurt them operating on them up front. As I mentioned earlier, we are studying the role of HPV in sinonasal cancer. Human papillomavirus is the same virus that causes cervical cancer in women, anal and genital cancer in men and women, and oropharyngeal tonsil cancers in men and women. And this is a unique type of carcinoma that biologically tends to behave differently, slightly more favorably, even though it looks like other types of squamous cell carcinoma. And we are currently studying this. We recently published a paper in Head and Neck on our experience with HPV and sinonasal cancer. So to summarize pathologic classification, what do we have to remember? We have to remember that there are categories of different types of cancers, some more favorable and others less favorable. Some where surgery would help upfront, others where surgery would not help upfront. And that's where the discussion regarding resectability of a tumor becomes very nuanced. And looking at two identical tumors, one would be considered resectable and the other one would be considered unresectable. Not so much because we cannot remove it with surgery, but because we are not likely to help the patient operating first. So let's talk about sinonasal cancer treatment. For early stages, doesn't matter what the histology is, as long as we're talking about carcinomas, not lymphomas, surgery is the first line of therapy. For advanced disease, T3 and T4 disease, surgery remains the first line therapy. And that's where the neurosurgeon and the rhinologist or head and neck surgeon meet. Because once we get to the orbit, once we get to the skull base, we are stepping into T3 and T4A disease. Once we get intracranially or in the cavernous sinus in the orbital apex is when we get into T4B disease. And that is where we fail with surgery. And that's where most of those tumors would be considered unresectable. Not because we cannot remove them, but because patients fail with surgery up front. And that's where new treatment options are very valuable. Just to refresh your memory, T4 is the most advanced form of local progression of cancer and is divided into T4A, moderately advanced disease, and T4B, very advanced disease. If you want to remember a few things, orbital apex, cavernous sinus, significant intracranial involvement upstages someone to T4B. So T4B for the nasal cavity and the ethmoid sinuses, orbital apex, dura and brain, middle cranial fossa, cranial nerves other than the second branch of the trigeminal nerve, nasopharynx or clivus would be signs of unresectable disease. We take this with nuances for some etiologies, for instance, adenoid cystic carcinoma. So when we look at treatment for unresectable disease, best treatment recommendation would be a clinical trial, usually a non-surgical clinical trial. So where did we get this information from? This is one of the largest landmark papers from the International Collaborative Group on sinonasal tumors involving the skull base. This was published in July 2005, and we are currently collecting data to publish a new series, again, a multi-institutional series that shows the outcome of craniofacial resection for sinonasal tumors, mortality close to 5%, complications close to 33%. As you all know, those are surgeries that could potentially go wrong for multiple reasons. But this is the paper based on which we know that operating with negative margins is what gives the patients the best chance of cure compared to operating and leaving positive margins behind. This is the paper that told us that different histologies in the sinonasal cavity tend to behave differently. That's the paper that told us that the extent of skull base involvement and intracranial involvement, whether you go from none to involvement of the bony skull base, to involvement of the dura, to involvement of the brain, progressively drops your chances of survival. Same thing for the orbit. No orbital involvement, minimal orbital involvement, or significant intraorbital involvement. And those are the factors that determine the T stage, and T stage is correlated with prognosis, as you all know. Reviewing a large series of 4,000 patients over the past 30 years, there has been a trend towards decreased utilization of surgery in advanced disease. And this is a paper that showed that microscopic positive margins or macroscopic positive margins do not do well compared to surgery with negative margins. And that's where neurosurgeons and head and neck surgeons have a different philosophy, where the concept of gross total resection that is included in neurosurgery for multiple tumors in multiple locations does not apply for sinonasal cancer. So if you remove the tumor grossly, but you leave positive margins, if you debulk a tumor, the patients don't do well. If you operate with negative margins, meaning an oncologic resection, patients do well. This paper also showed us that in advanced disease, when you operate alone versus when you operate and you add adjuvant radiation or chemoradiation, you improve patient survival. When you work on T4B patients, surgery tends to do very poorly for T4B, and that's where we need to step up our treatment paradigm. Endoscopic versus open resection used to be a very hot topic and a debate 15 years ago where people would get heated and argue. I think it's been established that the endoscope is a tool. You can use it to enhance visualization, to look around corners, whether you're working through the nose or whether you're working through a big incision. There's always a blind cut or a cut that is difficult for you to see because the tumor is in your way. And I use the endoscopes for that reason. You know, this is the concept of endoscopic versus open, and I'm sure we can debate this for specific cases, but basically with an open surgery, you start widely, and then as you get deeper, the field becomes narrower, and then you have to retract the brain to get the tumor out. Whereas with an endoscopic surgery, you start narrow at the nostril, and then you debulk the tumor, and then you have a much broader exposure. This being said, you know, I advise people to go beyond the debate of endoscopic versus open, but think about using endoscope as a technology and a means to get better visualization in some areas. You know, a more precise way to debulk the tumor, to track its base of attachment. There is enough data in the literature to say that debulking does not increase the local recurrence risk. Let's talk about orbital invasion. Well, as I mentioned earlier, involvement of the orbit upstages tumors. And when the orbit is involved in 80% of the ethmoid cancers, 80% of the maxillary tumors, this negatively affects survival and upstages patients from T3 to T4A and T4B. One landmark paper that came out of our literature in 2004 started talking about orbital sparing for advanced sinonasal cancer. The teaching used to be every time you have cancer coming from the sinuses into the orbit, you have to do orbital exenteration. There are multiple grading systems, but essentially minimal orbital involvement, extraconal orbital involvement, and intraconal orbital involvement do not all fare the same prognosis. There are some papers comparing orbital preservation in selected cases with minimal orbital involvement versus orbital exenteration, and survival is not significantly different. When we talk about orbital preservation, we want to make sure we don't preserve the orbit at all expenses and end up with fistulas and non-functioning eyes. So there's oncologic safety of preserving the orbit, but there are also practical, realistic expectations of having an anatomically preserved, but also a functional eye. So in terms of surgical treatment of sinonasal cancer, what I want for you to remember is, you know, no matter what type of sinonasal cancer you have, surgery is still the first line of therapy. However, the objective is resection with negative margins. Playing catch up is a difficult problem. If you have any question, take more tissue than you think, of course, within the reasonable extent of tissue possible. Surgery alone is still not optimal for advanced disease. That is where we fail. The endoscope is a tool with clear benefits for endoscopic surgery in small tumors and benefit of using the endoscopic technique in some large surgeries for specific cuts and specific angles. Orbital involvement is a prognostic and a therapeutic challenge. And every paper in the literature that has reviewed the outcome of patients with sinonasal cancers has demonstrated that centers that have high volumes and treat patients with sinonasal cancers commonly have better outcome than centers with low clinical volume for sinonasal cancer. So if surgery for advanced disease is not good and is not providing optimal cure, people have looked into introducing induction chemotherapy. And that's a paper from Italy talking about induction chemotherapy for orbital involvement. And according to this paper, in select high-grade tumors, induction chemotherapy resulted in successful orbital preservation in many of the cases. Disease survival depended more on the extent of orbital involvement. And as we mentioned earlier, the more the orbital apex and the intraconal spaces are involved, the less likely you are to survive your cancer. Not so much because you cannot remove it, but because those patients tend to fail both locally and systemically. Orbital exenteration showed a poor prognostic factor because this was correlated with more advanced orbital disease. T classification is always a determinant of prognosis. And as we mentioned earlier, different histopathologic types have different prognosis in sinonasal cancer. I'll let Dr. De Monte comment on this, but we have similar data to suggest the use of induction chemotherapy both for squamous cell carcinoma and for SNUC. This data came from MD Anderson and is very valuable. And we do have right now an ongoing clinical trial, a collaborative study group on use of induction chemotherapy in T3 and T4A disease with minimal skull base involvement to try to see if we can incorporate systemic therapy to improve the outcomes of surgery in patients with locally advanced disease. So how are we doing in terms of treatment of sinonasal cancer? We are starting to understand different malignancies. We're still not doing well with locally advanced disease. And as skull-based surgeons, that's what we deal with most of the times. We are balancing better the use of endoscopic and open approaches. We are starting to understand the systemic therapy in the treatment scheme for sinonasal cancers. We have not done very much in terms of studying disease-specific function and quality of life, and that's an area where we need to improve. So what does the future hold? A change in incidence, question mark, with the rise in HPV and HPV-related cancer, are we going to see more sinonasal cancer? And how is this going to change the overall incidence of cancer? With new technologies, are we going to be able to better tailor our surgical treatment? Will there be a more significant role for non-surgical treatment, especially for advanced disease? Sinonasal cancer is the example of a disease where multidisciplinary and interdisciplinary management are extremely important. And of course, as we fail with every other cancer, survivorship issues, hopefully, as we cure more and more patients with sinonasal cancer, we have to address their long-term survivorship issues. Thank you very much.
Suzuka, that was tremendous. I'm sure particularly young and old members of the audience appreciated your didactic way of putting it, particularly neurosurgical perspective. I'm not sure, honestly, in the audience if we have non-neurosurgeons, but perhaps we do. Perhaps we have medical students. I don't know. Today, I will know later. That was excellent. But can I, before I actually, just a quick question, because you brought it up before I move on to Franco. Can you make a comment on orbital involvement? Should we make a distinction between the medial wall of the orbit involvement versus pure periorbital involvement versus orbital fat involvement? Do we have data to stratify those three levels of involvement?
So as I mentioned in my talk, and I'll be happy to put the slide up again, according to the NCCN guidelines, T4A disease is involvement of the orbit. T4B disease is involvement of the orbital apex. And I think where we fail is
right.
more posterior, more central disease. Now, there are nuances with orbital wall, orbital fat, or involvement of the intraconal space. There are multiple grading systems coming from different groups, grade 1, 2, 3, or 1, 2, 3, 4. The biggest factor that changes prognosis is involvement of the orbital apex. As long as the orbital apex is not involved, I think your patient would be considered as having T4A, which is moderately advanced disease. This includes the lamina papyracea, the extraconal orbital fat, and also the intraconal, the muscles and the intraconal space. If the involvement is anterior away from the orbital apex, the prognosis is not as bad as when disease gets into the orbital apex. If you think about it, the orbital apex is the gateway to the cavernous sinus, to the nerves, to all the structures through which the cancer could spread very, very easily.
Thank you. Franco, let's have your slides if you don't mind. Thank you very much. And unmute your microphone.
Hi, everybody. So I'm going to try to give a neurosurgical perspective on the management of sinonasal malignancy or malignancy of the anterior skull base, not necessarily sinonasal.
Okay. Click on your slide with the left click, and then it'll advance.
Okay. So 1,500 skull base tumors. These are the malignancies, about 600. Really different between children and adults. As you can see, the breakdown is that the epithelial tumors arising from the sinonasal cavities are much more common than the adults, with sarcomas being less common. And that's the reverse in children, where the sarcomatoid tumors or sarcomas are more common. And they're distributed differently. In the adults, as you can imagine, the epithelially originating tumors are focused around the paranasal sinuses. And as you progress from the anterior skull base to the posterior skull base, the incidence of sarcoma progressively rises and epithelial tumors progressively decreases. In the children, the sarcoma is more common at all skull base sites. And as our previous speaker said, there's a tremendous diversity in the pathologies we see at the anterior skull base. And these are the sarcomas we see. Middle skull base, sarcomas are taking over, and they're a little bit different. Osteosarcoma. There's always this UC unclassified, which is a pretty large segment of sarcomas, which is slowly narrowing because of molecular identification now. And then finally in the posterior skull base. So those are over 35 different pathologies. There are 20 varieties of sarcoma, 15 non-sarcoma pathologies. So it really requires the expertise of multiple specialties in order to achieve the best patient outcome. And I'm going to focus on this throughout my talk on the importance of multidisciplinary care, because the best patient outcomes are only achieved when the best quality surgery occurs as part of a carefully constructed multidisciplinary management plan. This is an example. This is a gentleman who came in to see us with an acute neurologic deterioration. He was actually comatose, Glasgow, of about 12 from this large frontal lobe tumor with edema. He was pretty sick, and what you can see there's a hemorrhage associated with the back end of that tumor. So I elected to, we took him to the operating room emergently, and really we're not set up to do a formal craniofacial resection. So I just took out his intradural component. And that was sinonasal undifferentiated carcinoma. We went ahead after surgery and gave him 4 courses of etoposide and cisplatin. And you can see that slowly the tumor responded incompletely, and there was actually some recurrent, reossification of his paranasal sinuses. We then came back and actually did a formal craniofacial resection and followed that up with external beam radiation therapy. And he's been rendered free of disease. He continues to be free now, I think 13 years later. And when we looked at his pathology from his second resection, could not find a viable cell. So I think the importance of the chemotherapy in this patient is clear in this kind of a 2-stage unusual sort of clinical picture. And here's a clearly unresectable squamous cell carcinoma treated with neoadjuvant carboplatinum, paclitaxel, and gemcitabine with post-chemo radiation therapy in 30 fractions, and there was a complete response, which was durable in this patient. So this is our institutional 3,500 plus sinonasal cancers, and the importance is the management has been increasingly multidisciplinary over time. It has moved away from surgery only to a more multimodal therapy. And this study was mentioned earlier. And what we did is we looked at our, and this was published in, I can't remember which journal, but sinonasal undifferentiated carcinoma. We took these patients with biopsy-proven SNUC, and 95 of them were treated with neoadjuvant chemotherapy. And they were either a complete response or a partial response in 64, or a less than partial response in 31. And this is their management. And what we found here is examples of response, partial response, stable disease, and progressive disease. And what we found, overall survival in this group, 5 years, was 59%, with a disease-specific survival of 59%, overall survival 56%. But what happened when we looked at those patients that responded, the overall survival was significantly better in those patients who responded to their chemotherapy, both the overall survival and disease-specific survival. And then we tried to break that down a little bit more. When we looked at overall survival, those patients who responded did better with chemoradiation therapy than with surgery, both overall survival and disease-specific survival. It was actually very significant for the overall survival, where those patients who went on after a response to chemoradiation therapy did better. And when we looked at the responders versus the non-responders, both in overall and disease-specific survival, induction chemotherapy followed by chemoradiation therapy had a significant survival advantage, both overall and disease-specific, in the responders. In the non-responders, then that's where surgery actually had a better outcome than using the chemoradiation therapy. And when we looked at the different issues, so in the first panel on the top left, it shows us our disease-specific, disease-free survival. And in those that responded and then had chemotherapy, did slightly better with disease-free survival. And when we looked at local regional recurrence, again, those with induction followed by chemo did slightly better. All these are non-significant compared to the overall survival, which I showed you earlier. And what we think is happening is that because of the aggressivity of the tumor, going to surgery takes the patient out of treatment for a significant length of time. So we start with the patients with induction. If they get a complete or a good partial response, we don't want to take them out of therapy for 4 to 6 weeks for surgery, healing, chemoradiation. If we move directly to chemoradiation, we get the survival advantage in that group of patients, those complete responders and partial responders. Those patients who have a poor response to induction, the stable disease or progression, then they are immediately in a poor outcome group. And the only real chance we have of salvaging those patients is to go straight to surgery followed quickly by chemoradiation therapy. So this is out again, responders to induction chemotherapy who are treated with chemoradiation therapy have good disease control, organ preservation, and improved survival. Non-responders to induction chemotherapy are best treated with surgery if resectable. So we we've made slow gains over the past 40 years, and we want to not lose those things. And anything new has to be tested against this. And what I look at when I think about my outcomes is really the MRI era forward. Looking at all those historic papers from before 1990 is somewhat useless because there's no way to really identify the full extent of tumor involvement. You could not grade the resection afterwards. From 1990 ish on the techniques of craniofacial resection, microvascular reconstruction, and open skull-based approaches were mature. And, at least 3D radiation planning was uniformly being used. So this is, again, the 3,500 patients at Anderson and by decade of therapy. And there has been an incremental increase from the 40s up to the more current data. And EHAB hasn't given me the more recent slide, but so this is from the data up to 2015, showing incremental improvement. And this is, again, a different way of looking at that at 3 years and at 5 years. The lines, at least in this study, are not flat. And the progress is probably attributed to more effective surgical therapy made possible by the advent and subsequent refinements of craniofacial resection, including the use of endoscopic surgery, more effective reconstruction using vascularized flaps, more effective adjuvant therapy, particularly conformal radiation therapy, and the use of novel adjuvant and neoadjuvant chemotherapeutic plans. So, again, this was a big debate back in the day. But I think the truth is that the best quality surgery is really only achieved using a multidisciplinary team of experts, which are facile with all approaches to the skull base. And this is our group. Ehab and I, and Paul is our neurotologist, Mike, Shirley, Sean, and Mark Ellie. And each one of our patients is discussed in front of a multidisciplinary management group. And again, the best outcomes are only achieved when the best surgeries is part of a multidisciplinary plan. So when we've published these over the years, outcomes for anterior skull-based malignancies, lateral skull-based malignancies, sphenoid sinus malignancies, and these there. Then we looked at outcomes by histology, what you can expect with high-grade and low-grade sarcomas, 5-year survivals, what you can expect with olfactory neuroblastoma, and the poor survivals that we're still seeing with mucosal melanoma. Adenoid cystic has good disease-specific survival. It's at 70% at 5 years. A lot of these patients do have tumor chronically. And then we also have a paper on squamous cell carcinoma and having better survival in chemo responders. These are the papers that we published for endoscopic resection of sinonasal malignancy. I think our group and the Nicolai in Italy published these large papers in 2009, really showing no significant survival advantage between exclusively endoscopic approaches versus cranioendoscopic approaches. That data has remained good up until most recent paper we published this year in 2020. And basically, as our previous speaker said, it's a tool and it has certain advantages, and appropriately utilized, I think that it really is not a if and or, it's when to use that. And again, this debate is gone. It's really criteria. And the criteria can be by stage, site, histology, whether or not you're doing a curative operation or a palliative operation, and to some degree, a comparison of the complication rates associated with each of these modalities of surgery. So, for example, this is not a great endo-only case. You got invasion of the parietal fat on the first panel. You have extensive invasion of the brain extending laterally in the second panel, and then you have very, very anterior disease in the third panel. These are best managed with a combined procedure rather than a endoscopic only type of procedure. These are great for endoscopic only. These are limited central disease inside the margins of the orbit. These should be treated endoscopically. There's no real question about that. And sometimes you just need to palliate somebody who has no ability to breathe. This is the group in England has pioneered this reestablishing airway passages for patients as a mode of palliation for mucosal melanoma. Again, over these patients, which are not all skull-based, but you can see again the outcome distributed by pathology. Our olfactory neuroblastoma patients are the best outcome group, followed by adenoid cystic, and melanoma is the bottom group. So the morbidity in our data with this paper was on 250 craniofacial resections. The morbidity in that was 5.6%. The majority of that morbidity was actually due to what I call the intracranial hypotension syndrome, precipitated by the placement of a lumbar drain. And you can see our CSF leak was quite low. So, and then the morbidity associated with the treatment of the disease rather than the surgery itself. And I've started classifying my complications using the Clavian-Dindo classification of surgical complications. And for example, a grade 3A would be an insertion of spinal drain, or the elective evacuation of a hematoma, or that'd be 3B. An emergent evacuation hematoma would be 4A. And this is our, this is another 190 craniofacial resections, and I've divided them by decades because I can, unfortunately. And what we see over the decade is that there's been a significant reduction in our complication rate over the period of time, significant between the 90s and the 2010s. And the thing we noted is that there was a significant reduction in the incidence of all complications, and especially the intracranial hypotension syndrome complication, when we stopped using the lumbar drain. So we've not used a lumbar drain for open craniofacial resection for many years. And again, at the bottom, you can see what has happened over the decades in our surgical approach selection. In the 90s, certainly we're doing a fairly traditional transcranial transfacial approach. We, in the 20s, migrated towards either pure transcranial, but you can see the rise of the transcranial endoscopic combination in the 2000s. In the 2010s, you know, the pure endoscopic resections have significantly increased. So the cranioendoscopic approach is a great approach. This is a classic olfactory neuroblastoma, extension a little bit laterally to the left. And, you know, we're all familiar with the bifrontal craniotomy, the en bloc ethmoidectomy, the pericranial repair. The open view is on the left, sewing in the vascularized pericranium. And on the right is the endoscopic approach, showing that reconstruction from below. So we like this approach a lot. It avoids facial incisions. It leverages the superior navigation of the sinonasal cavity afforded by the endoscope. It gives a panoramic, unobstructed view to the entire floor of the anterior skull base. It gives you the ability to manage dural defects by direct watertight suture. You can use a robust, reliable reconstruction with vascularized pericranial tissue, especially if you have to resect all the upper nasal septum, which you often have to. And it gives you improved options for both orbital, cerebral, and frontal sinus extensions of the tumor, and direct visualization of the adequacy of your reconstruction at the end of the procedure. So the role of surgery in the care of patients with malignancy of the skull base is clearly evolving. And we need to step back and reevaluate the timing, the extent, and the goals of surgery. The neurosurgeon needs to be actively involved in this and participate in the creation of these multidisciplinary, multimodal plans. You hate to be, you know, told what's the thing that's going to happen to your patient. I think you need to be there at the front line. And patient selection really remains critical in determining the optimal surgical approach for these very challenging neoplasms. Again, I want to say it again for the third time, the best patient outcomes are achieved when the best quality surgery occurs as part of a carefully constructed multidisciplinary management plan. Thank you very much, and that's what I have for you.
Franco, fantastic. Amazing multidisciplinary institutional experience, which of course you've been the pioneers in, and I think we'll save questions till the discussion time. So I'm going to invite Albert, who could unmute his microphone and share the case or the thoughts he had for you, Suzuka, and the rest of the panelists.
I'll just get my presentation in order.
And while you're doing that, please tell the audience what you've been involved in, that Brainworks show.
Yeah, no, that's a great idea. So again, great talks, and I some amazing points in both talks, and I think for both speakers, I think one of the big emphases is that, you know, surgery is not the end all here, and clinical trials moving forward are obviously going to be very important with the acceleration of molecular pathogenesis. So, okay, BrainWorks, by the way, is something Eric Luthard and I did, and this sounds random, but it's something we did a couple of years ago with the local PBS network here, and then we did it again a year ago. It's essentially a play, so it's different from Lenox Hill. Lenox Hill is more like documentary style. This is more sort of art reflecting reality. So there are basically stories about relationships and people's diseases and sort of the neuroscience involved in it. And most of all, it's about Eric and myself just basically nerding out about neuroscience and just telling you how neuroscience affects all aspects of your life. You know, what is your sympathetic nervous system doing, for instance, when you're on your first date with, you know, with a girl, for instance, what is, you know, pupils dilating, things like that. So if you want to check it out, it's on PBS across the country. It depends on what city you're in. Again, you can just check your local PBS. But
so what's the appropriate age to start watching this show then?
I would say, you know, 10 and above, honestly.
Okay. All right.
Yeah. It's PBS friendly, you know.
That's fun. That you must tell us later more detail on another session.
Yeah.
What a great experience. Okay, thanks.
Yeah. So this some again amazing talks. It's the experience of both Drs. Sargi and De Monte is just incredible. I was just going to show a quick case here that we saw, and this was in collaboration with somebody probably very familiar to many of you. Dr. Sargi, you probably know Christine Klatt-Cromwell quite well. She is a really an amazing rhinologist and ENT surgeon who joined us a few years ago. She's the one, she and Dr. John Schneider are really the ones I do the big cases with here, anterior skull base. So she brought this person to me. This is a 6-year-old guy with 3 months of nasal obstruction and intermittent epistaxis. And CT showed the following. You can see the changes in the anterior skull base bone, the movement of the crista galli to the left, for instance, fovea ethmoidalis, sort of lytic changes, and then the MRI looks like this. There was suggestion that the dura was involved, and in fact, even perhaps past the dura, as you can see here. All right. And this is a non-contrast, but the best sagittal I could find. And then just some more evidence. There's this hint here it's creeping into the dura here, okay? And mucocele in the front. So endoscopic biopsy was done by Dr. Klatt-Cromwell. It showed a large cell neuroendocrine carcinoma, and the PET scan of the body showed just one mass in the, you know, just that one nasal cavity mass. So what do you think about this?
Franco and Zuka and Jim and Pablo, just unmute your microphones so you can all chime in.
Okay, yeah, so neuroendocrine carcinoma is potentially a highly chemosensitive tumor. So, you know, I would start with induction chemotherapy in this patient, usually with a etoposide platinum combination with a pretty good expectation of a significant response. And if the response is complete, then I would go straight on to consolidation with chemorads. If it's incomplete, then I would resect the residual, look at it for tumor, and then probably follow that up with chemorads as well.
Zuka, any disagreement with that strategy?
Not at all. I completely agree. For the audience, just as a reminder, you know, neuroendocrine carcinomas are a large group of tumors. They could include some of the SNUCs, some of the high-grade esthesioneuroblastoma. So that's how we think about high-grade neuroendocrine tumors. And I would completely agree with induction chemotherapy first and follow as Dr. De Monte discussed.
So interestingly, our chemotherapy, our medical oncologist actually did not suggest chemotherapy as first line. I would actually love to discuss the reasons with that person why, but they actually suggested surgery and radiation therapy for us in this case. So we did essentially a resection first with a lumbar drain and anti-skull base drilling, including the ethmoids, cristogali, dural resection, etc. We essentially took it en bloc after drilling the bone around the involved anterior skull base. When we got in through the dura, the right olfactory bulb was bulging with cancer cells, which we also resected. And we performed a pericranial graft with using a small endoscopic incision, which is familiar to most of you. And this is actually his pericranial graft. Afterwards, he received radiation therapy, and that was about, I would say, about 19 months ago. But I think chemotherapy, so I appreciate that.
Albert, was the nasoseptal flap not viable, or was it involved by tumor? Is that why you used the pericranial flap?
Yeah, no, it's a great question. So the right obviously was involved, and then I think Dr. Clark-Rommel wanted to use the left side, and she sampled it, and it was positive margins sort of around the flap itself on the left. And so there we decided to do the, in fact, it was fascia lata first, and then is an inlay, and then followed by the pericranial graft.
So Albert, just to
By the way, sorry, Albert, can you stop sharing your screen anyway?
Yeah. That's a good idea.
Yeah, just to follow up on the NCCN guidelines, what you did is you followed the NCCN guidelines, and according to the guidelines, your patient had T4A disease, and recommendation is for surgery followed by radiation. Those nuances that high volume institutions have sometimes are not in line with the NCCN guidelines. The NCCN guidelines are a preference, but some institutions may have some preference. So I think you did the NCCN guideline appropriate treatment. So the concern with high-grade neuroendocrine cancers is that patients have systemic failure. They fail from distant metastasis. Once the dura is crossed with high-grade neuroendocrine cancers, they're at high risk of having either multifocal diffuse intracranial recurrence or systemic metastasis. And that's where selecting the chemosensitive, the chemoresponders helps in tailoring the treatment. So, but this would have been perfectly suitable for an endoscopic resection had we decided to proceed with surgery first on that patient.
Suzuka, though, let's say we did induction chemo and it partially responded. So when we would do the resection, we would still resect the dura, even though the tumor may have retreated from the dura. Wouldn't you agree? So we're going to still cross the dura.
So the response to induction chemotherapy is not as, sometimes tumors shrink in a centripetal way, and sometimes tumor cells die wherever they are. And, the original areas involved by tumor are the same ones that you need to operate on. So to phrase this differently, induction chemotherapy does not make an unresectable tumor resectable. Induction chemotherapy could make a borderline resectable tumor a better candidate for surgery because the patient responds. If you have a tumor that's borderline resectable and the patient does not respond to induction chemotherapy, as the papers from MD Anderson show, if you are not a good responder to induction chemotherapy, your prognosis is bad no matter what treatment you get. And then, chemotherapy with radiation or just palliative radiation would be the way to go if someone has a borderline resectable tumor and they do not respond to induction chemotherapy.
Thank you. No, that's very informative. I appreciate it, Dr. Sarji.
If there are no other comments, I'll invite Jim to share his slides. And Albert, whenever you're needed in the OR, you are excused, or hopefully you can join us the rest of the session.
Thanks. I'll try to stay on as long as possible.
Can you see my slides?
Yes.
Okay, great. Jacques, actually, I've been a full professor now for 2 years.
Oh, did I put associate professor? I apologize. Did I do that? Okay, I apologize.
Maybe
well,
my,
you've always been a professor.
My website probably needs updating, so
Your web? No, that's right. Actually, we took it from your website, from your medical school website. You're right.
I'll blame them.
Please do. Well, you've been born a professor as far as I'm concerned.
So this is a 26-year-old male who presented with left orbital proptosis, nasal obstruction. This is the coronal MRI. You can see an enhancing sinonasal mass primarily in the left nasal cavity, goes up into the ethmoid, and looks like it's involving the orbit and the left anterior skull base. Here's the sagittal coronal, and here's the axial, and I'll give you the finer cuts of the axial, and I'll raise the question. I know Zuka covered this very nicely in his talk. Is this 4A or 4B based on what you described as the orbital involvement? And how would you grade it?
So of course the question is not an easy one to answer because this is a borderline. This is not a straightforward T4A or straightforward T4B. If you
want coronals to have a better look?
Oh, I'm sorry, I don't have all the coronals. These are the ones that I have. This is towards posterior. This is more anterior to the right.
What I would like to comment on is the tissues surrounding the edges of the tumor. And this is a tumor that looks like it has more pushing borders than infiltrating borders. You can see the medial rectus on the axial cuts nicely displaced medially, and you can still see maybe a little bit of fat around it. You can see the orbital apex fat completely normal. The tumor may be creeping in between the medial and the superior rectus posteriorly, but I would probably not consider this an obvious orbital apex involvement. So I would say this is a big T4A verging on T4B, but I would not commit on saying this is unresectable.
Zuka, I have a question just to follow up on Jim's question. Dural involvement is a component of the grading, correct? And so if we look at the coronal, right, especially in that middle cut, would that push you more on the 4B side, or
the T4B is significant dural involvement. So minimal dural involvement would not qualify for T4B. Now, all those terms are not very specific because what would be significant dural involvement for some people would not be considered significant dural involvement for other people. That's where I think the pathology of the tumor is going to determine whether or not we talk about resectability, and then the radiologic nuances become almost not so relevant. This is a unique tumor, and its epicenter is almost in the bone of the middle turbinate, and it's almost seems to be expanding the tissues both medially, laterally, and superiorly. I look forward to hearing the rest of the story.
Okay. So, of course, we started with a nasal biopsy by my ENT colleague, Anderson Eloy. And the pathology was an adenoid, sorry, I misspelled this, adenoid cystic carcinoma, and the PET scan workup was negative. So I'll start with Dr. Monte. How would you manage this in your practice as the next step?
Right. So there is no really effective chemotherapy for adenoid cystic carcinoma. The response rates are an average 30 to 40% at best. So we would resect this surgically and probably follow it with, probably in a young person at 26, probably give them radiation therapy with cisplatin post resection.
What would be your surgical approach?
This is going to need a cranioendoscopic approach. I think the periorbital membrane is really best controlled from above, because you can take it over from just above the superior rectus and levator complex, bring it around medially from above, and then our, the ENT surgeon can remove it from below. I think trying to get a scope up in that corner is fine. You can do it, but I don't think you're going to get the microscopic resection that you need to get for this kind of patient by endo-only approach. So I would do a cranial-endoscopic resection.
So you would try to preserve the globe,
Yeah.
not do an orbital exenteration.
Well, not prima facie. I mean, I think the patient would have to understand the necessity of that oncologic maneuver should there be frank invasion of the orbital fat and the extension deeply into the orbit. But given what the appearance of this, it's likely that would not be necessary. I think we'd have to resect all the medial and possibly most of the superior periorbital membrane, but I don't think the eye needs to come out.
Franco, I agree with you, but for a different reason. I mean, as you said, indeed, you can get to laterally to the mid coronal plane of the orbit. But the reason I would probably add a craniotomy is mostly to reconstruct the dura that far laterally, not so much because we cannot resect the disease endonasally. And I've always done it when I've done it less and less, of course. Craniotomy style is kind of suturing a patch in the edges of the dura under the microscope to make it watertight.
Yeah, I guess I that was kind of a given in my mind. Yeah. I think the dural resection is going to be wide, and direct suture repair is the way to go here.
Right.
And you might be able to salvage maybe the flap on the right, but it'd have to be sampled to make sure there's no cancer in it. Certainly, you're not salvaging the nasoseptal flap on the left at all. So I think you have to, having the pericranial graft available is going to be pretty important.
Suzuka, would you do this any differently?
So, I would first question the diagnosis and twist the arm of the pathologist because this is a very unusual adenoid cystic carcinoma in a young patient. But assuming that's the diagnosis, this is the case.
Sorry, tell the audience why you say it's unusual.
So adenoid cystic carcinomas are usually tumors that have ill-defined borders that have a tendency to spread along nerves. If you don't see perineural spread of disease, it's very hard to call it adenoid cystic carcinoma. And as I mentioned earlier during my talk, there are some lesions that look like adenoid cystic carcinomas, but that are actually not adenoid cystic carcinomas. And the key to diagnose an adenoid cystic carcinoma is looking for the MYB mutation. So unless the genetic testing was done and the MYB mutation was confirmed, I would challenge the pathologist to call this adenoid cystic carcinoma. Now, this being said, that could be adenoid cystic carcinoma. If that's the case, I would be prepared for a much bigger resection than the boundaries of the tumor on MRI, because adenoid cystic carcinomas typically extend beyond the edges of what you can see on MRI. And I would have to be prepared to chase branches of the trigeminal nerve into the pterygomaxillary fossa, which we could very easily do endoscopically, but also up into the cavernous sinus. The cavernous sinus involvement makes almost every other tumor unresectable, but for a young 26-year-old with adenoid cystic carcinoma, I would not take the patient to surgery without their consent for an orbital exenteration, a free flap, a balloon test occlusion, and a cavernous, a consent for chasing disease into the cavernous sinus. So this is probably the head and neck surgeon talking, not so much the rhinologist. I would still use telescopes, even if we're doing this as a big open craniofacial surgery. But I would try to get this patient the surgery that would achieve negative margins from the first time.
Agree completely.
So I think radiographically, we didn't see any cavernous sinus involvement, and it didn't look like that was apparent surgically as well. So our strategy was to do a pure endoscopic endonasal, but we always prepare for and consent the patient for possible craniotomy at the same time for the purposes of whether we need to do more controlled intracranial exposure and get negative margins, but also in case we need to use the pericranial flap as the reconstruction source. And our goal here was to preserve the orbit if we could for better quality of life. And here's an operative video. This is looking into the left nasal cavity. This is the tumor mass. We initially debulk it with a gyrus microdebrider, which will, what Suzuka said, gives you a wider exposure later on in the case. But in the beginning, it's quite narrow because your corridor is filled with tumor mass. So you do have to debulk this. This is not an en bloc resection. And as you get more exposure here, we're seeing the floor of the nasal cavity, and we'll now do a left medial maxillectomy where you resect the inferior turbinate and open up the medial maxillary wall. You get wide exposure and control of the maxillary sinus. There's the choana in the back medially and the sphenoid sinus just above. And now we'll use a 30-degree angled endoscope looking upwards and debulk the tumor that's in the ethmoid cavity. And this will eventually take us up into the left frontal sinus. Here we're looking up into the left frontal sinus, and that's the posterior table of the frontal sinus that we're seeing, which is a very important landmark when you're doing your transcribiform resection. We'll now do a superior septectomy, which allows us the neurosurgeon to work binostril. So you need this septectomy so you can introduce 2 instruments, 1 in each nostril, and you get good control over the cribiform plate. There's the posterior table of the frontal sinus. And we do a modified Lothrop procedure, which is a draft 3 frontal sinusotomy. And that's important because that posterior table acts as the shelf where you lay your nasoseptal flap to make contact on that bone. And so we'll do our cribiform drill out, and there's the dura. And then we'll make our dural cuts to excise the dura. We usually like to make longitudinal cuts first along the sides, and then we'll make the transverse cut anteriorly. And you have to get control of that falx cerebri, which can be a little tricky sometimes, but what you do is you take a heavier blade scissors and you transect the falx from an anterior to posterior direction. Now you have to be careful not to cut upwards, and it's easily to misguide yourself and go upwards, but you need to go transversely in the sagittal plane. And then we'll resect the olfactory bulbs here and then make the cut posteriorly along the planum sphenoidale to make that last transverse cut. And there's the tumor. There was no brain invasion. It peeled off nicely off the pia arachnoid. And so that completes the anterior skull base resection. But now we have the orbit to deal with. So what we like to do here is to reconstruct initially first before we resect the orbit, so you don't have the orbital fat hanging out and blocking your view of the reconstruction. So we'll do a triple layer reconstruction using fascia lata as the inlay, and then this Cassiano Miami style alloderm plug. That's an inlay overlay. And now we'll go ahead and before we put the flap up, we'll excise the periorbit and explore the orbit. And this is 2-hand microsurgery, which is helpful to dissect the tumor. And the tumor had a nice capsule, and you could separate it from the orbital fat. So it didn't feel like there was any orbital fat invasion. And we felt that we were able to achieve a gross total resection here to remove the orbital mass and get a negative margin resection. And then lastly, we'll put up the nasoseptal flap to complete the 3-layered reconstruction. And then this is the article where we initially described this triple layered reconstruction with the fascia lata followed by the Cassiano alloderm. Further revised this recently, we noticed that when we're doing these anterior skull base resections, the nasoseptal flap has a hard time reaching in some cases. So we make a little relaxing slit that I call the sphenoidal slit incision, which is just above the floor of the sphenoid. You make a relaxing incision in an incremental fashion, and it gives you an extra reach anteriorly to release the tension. But then you have this redundant mud flap that I call that you can rotate posteriorly and upwards to make contact over the planum sphenoidale. And this is a nice little technique that's worked for us for these large defects. And here's the immediate post-op scan with the reconstruction. And then you can see here's the scan at 5 years. And at 5 years, he has not had a local recurrence. He did have, he went on to get radiation therapy, but he did have pulmonary metastases at 2 years, and he had a lung resection, wedge resection. And then at 5 years, he had some recurrent nodules that were stable, but he was still alive at 5 years since then. So I guess the questions I have for the speakers and the panelists are the role of orbital exenteration, when to perform on block resection, is that a thing of the past? And chasing the negative margin, does it matter? And any other comments that you may have?
So negative margin is critical. I think in every paper that we've written and the literature would support is that achieving negative margins, and it doesn't have to be on block, it could be piecemeal, but the margins, when they're negative at the end of the resection and they have to be microscopically negative, that's when the maximal survival advantage is achieved. So I don't, it doesn't have to be on block, but I think the goal of any surgery for malignancy should be microscopically negative margins. And the orbit, we, like everyone else has been looking at orbital preservation. And yeah, I think that's okay. But again, leaving microscopic disease inside the orbit is not ideal. We've taken on a bunch of lacrimal gland adenoid cystic carcinomas in an orbital sparing maneuver, and I regretted about half of them with local and distant recurrences. So it's a two-edged sword. Certainly, it's best to leave a functioning eye, but to open somebody up for multiple recurrences and is also a problem. And the other thing we've noticed in some of our more recent literature that's coming out is that a microscopically positive margin also ends up directly relating to increased incidence of systemic disease. So I think leaving microscopic margins not only opens you up to local recurrence, it does actually increase your incidence of systemic. So we're pretty bullish on negative margins.
If I would add one thing as well to Franco's comments, although this is a group mostly composed of surgeons, our radiation oncologists would remind us that radiation to the orbit itself is not benign, and many of those patients can have painful red eye and even lose their eye from the radiation therapy itself. So just because we preserve the function of the eye in a temporary fashion with surgery, that may not mean in the end during that patient's cancer treatment that their eye function is preserved.
To add the perspective of the head and neck surgeons, we as head and neck surgeons have become much more conservative in managing the eye. And my personal philosophy is I would take the eye out. I would do an orbital exenteration if this clears the last positive margin. Meaning if that's the only place where there's disease left behind, and by taking the eye out, I would clear that last margin. I certainly would not take the eye out in someone where we're going to have multiple positive margins everywhere. I don't think it makes sense because taking the eye out is very mutilating for a patient. If however they have disease and the only thing that's standing between negative margins and clearing the disease is the orbit, then orbital exenteration is what they need.
Franco, can I ask you, do you guys at MD Anderson ever tailor the orbital exenteration or the degree of orbital exenteration? For example, do you ever leave the globe in and exenterate the retrobulbar, the behind, the fat, the muscle and nerve, to keep the globe, if it survives, the loss of the ophthalmic artery, to keep it as a natural dressing? You know what I'm asking?
Yeah, I get you. No. I guess, first of all, the
But-
EO would be non-functional, right? Because you're-
Correct. Right.
And so then it would be automatically enophthalmic. So if we're gonna do a resection of the orbital contents, we take the globe.
So it's an all, you do it as an all or none. Yeah.
No, I wouldn't be that dogmatic. I think, if it's for example, let's say there's some localized invasion of the medial rectus.
Yeah.
We'll resect the medial rectus.
Okay. Okay.
And maybe some fat around it, to get that negative margin. But if we can't do, because that results in obviously some diplopia, which can be managed with some vitreoculoplastic surgery, and movement surgery. But in general, if you have deep invasion in the orbit, we take it off.
Yeah. That's the area where having outstanding oculoplastic surgeons would add to the multidisciplinary team yet another perspective. And, we have 8 oculoplastic oncologic surgeons in Miami. And because of them, we do tons of orbital sparing procedures. But unless you have that kind of support, I think just preserving an organ may be very challenging. And, there are cases where we end up having to take the orbital contents out after cancer treatment has been completed, not so much for residual cancer, but to deal with a non-functioning, painful, and sometimes ruptured globe.
There are orbital prosthetics also that can be used postoperatively for cosmetic reasons. If you have a good team, I don't know what the specialist is called, but
Anaplastologist.
Great. Jim, great case. By the way, I did double check. Yes, your medical school still has you as associate, but your hospital.
Dr. Ivan, I think Dr. Mac, we lost Dr. Marcos. Dr. Ivan, you here?
Oh,
you're back. Hey.
Yeah, you know where I am, where I don't have great Wi-Fi. I don't know if Jim heard me, but go, Pablo, let's have your slides, please.
All right. So
by the way, if I disappear again, Zuka, please finish the session in case
I think Mike is still here as well.
No, Mike had to go to the OR.
So I just briefly wanted to thank Jacques and Mike and the rest of the organizing committee for a wonderful opportunity to be part of this panel. Jacques has been who has become a dear friend over a long time, and I very much appreciate every time I get the opportunity to chat with him. For me, it's a big pleasure also being on here with Suzuka and Franco, and Franco specifically was my mentor without having ever trained me. I think one of my very first really massive lateral skull base procedures, which I was trying to refer to him, but because of insurance reasons stayed with me. He was really instrumental in helping guide me, and I'm forever grateful for that. So in these type of cases, you need friends like that. So all right, here are my disclosures. So I'm just also going to present a third case. This is a 56-year-old guy. He started having obvious right enophthalmos, nasal obstruction, epistaxis, diplopia. You can see the rest of his exam, but he ended up having a large mass, which was seen on nasal endoscopy. This is what the mass looked like on CT scan. So just a couple highlights. You'll see most of the anterior skull base bone, as well as the posterior table, the frontal sinus has been destroyed by the tumor. There's some extension over to the right orbit. And this is what the MRI scan looks like. So there's of note also kind of extension up not only on the frontal sinus, but suspicious in the area of the superior sagittal sinus. So the patient underwent a nasal biopsy, which you can read here, but really poorly or undifferentiated squamous cell carcinoma or a high-grade adenocarcinoma. They were a little bit on the fence. They did a lot of the molecular markers, as you can see. So with that in mind, let me start out just and ask some of our main presenters. Suzuka, this is a T4B, right? Clearly?
Yes.
Okay. And so of note, the patient also had other workup, including PET scan, which showed that this was the only lesion. So my question would be, with the grading system and with your very didactic original presentation, are all T4Bs the same? You know, this has dural involvement, likely orbital involvement, and superior sagittal sinus, but is this going to have the same outcome as a patient that has the same tumor that extends back to the cavernous sinus?
So unfortunately, I don't think we have the data to give you a specific answer, meaning is T4B by extensive dural involvement up to the superior sagittal sinus worse or better than T4B by involvement of the orbital apex or the cavernous sinus? We know altogether that T4B patients do not tend to do well, and we know that T4B patients do not tend to do well with surgery as first-line treatment. So would we treat them all the same? I don't think so. I think the histology matters. The fact that they couldn't differentiate between a high-grade adenocarcinoma or a high-grade squamous cell carcinoma or a poorly differentiated squamous cell carcinoma tells me that this is a high-grade tumor. A high-grade tumor that is T4B with this extensive disease would probably not best be served starting with surgery. The question of squamous versus adenocarcinoma is going to be crucial because your medical oncologist will decide what type of induction chemotherapy to give based on whether or not this is a squamous cell carcinoma, a neuroendocrine carcinoma, or an adenocarcinoma.
Franco, can you comment a little bit on, add to what Suzuka has said in terms of the grading system and some of the nuances within, say, a T4B, and how you as a neurosurgeon would say something will be unresectable versus, no, actually we can go after this? And perhaps your perspective and how it has changed over time.
I apologize for what I'm going to say right now. I completely don't pay attention to the staging system whatsoever. It's either a big tumor or not a big tumor. It's either resectable or not resectable. All tumors are operable, so that's never an issue. You can always do an operation of some kind. I think you have to look at what what is going to be my ability to achieve a margins negative resection and minimizing patient morbidity and optimizing their outcome quality of life. So I think, to me, that goes beyond the staging system, right? And I think, as you can tell, this arguing between a 4A and 4B is not getting to the heart of the matter, which is, again, optimizing patient outcome, and there are the little nuances on a case-to-case basis are really important. I agree completely, Suzuka. This is a big tumor. It's a poorly differentiated tumor. You could take it out, no question about it. This could be removed surgically. You have to think about some things. You're probably going to lose the frontal bone because there's involvement at least to the anterior table. So that's an issue. You're right back to the nasal bones. They may be an issue. It's hard to tell if there's anything going up into the lacrimal duct area. Those could be issues. But I think likely once we had the pathology a little bit more nailed down, we'd probably start with induction chemotherapy.
Okay, so I think that this is a good case for this because it highlights several important points. It marries the data-driven which both Zuka and Franco, you guys are some of the most didactic, data-driven people that I know. But at the end, you know, there are nuances which are individual to each case. So, all right. So what to do now? Surgery, neoadjuvant chemotherapy. Franco, you alluded to, if not knowing anything different, you probably would do neoadjuvant chemo. I'm guessing. Zuka, are you in agreement with that?
Yes. Well, I may do more surgery to get more tissue for the pathologist to be able to tell me what type of tumor it is, because, you know, if sampling was an issue, and that caused them not to be able to call it either adenocarcinoma or squamous cell, then surgery is definitely justified, not so much to resect it, but to improve your sampling and try to get a more specific diagnosis. That's what I would suggest. Get more tissue, get a more accurate diagnosis, and tailor your treatment based on that.
Okay. So very important point that you really want to be sure. Another difference in how traditional neurosurgery is a little bit different than these combined surgeries where our worlds collide, where we will frequently just operate on things a little bit more aggressively in the traditional neurosurgery realm, but where tissue is really the issue. You know, our group thought that the sampling, you know, that they had good sampling. I think it's a good idea to consider repeat biopsy. Sorry here. All right. And so we did go in through a course of an induction chemotherapy, carboplatin and etoposide. The patient did have, I'm not going to belabor some of this because Franco has and Zuka have covered some of these points. The patient did have an initial response, some improvement in pain, and some improvement in the diplopia. However, it was not long after that he failed. So at this point, you know, we re-imaged him. Here's what it looks like, and so the decision that our group was for surgery. So
what's the time interval, Pablo, from initiation of induction chemo to this MRI approximately?
2 months.
2 months?
Yep.
Progressed after only one course then?
He had gotten a second course already, Franco. He was not fully through, but his symptoms had progressed significantly where we got repeat imaging. So here are some options, but what I'd love to hear what you guys think of how you would do it and why, or if you would do it.
Pablo, I'll answer first. I'll do open craniofacial on this one because of the argument we discussed earlier, laterality and extensive dural involvement.
So not only that, look at the superior involvement of the posterior table of the frontal sinus. There's no way endoscopically you're going to be able to reach, even if you can see the extent of involvement superiorly. You don't have the instruments and you don't have the reach to adequately resect the superior extent at midline on the sagittal cut at the level of the posterior table of the frontal sinus. And then, you know, when you have this much orbital involvement, I think you start losing, especially for a high-grade tumor, that did not respond to chemotherapy. So, like, if you tell me operate on this gentleman, I would say open craniofacial. You can use the endoscope for certain cuts, like intranasal cuts, like the posterior cuts. But, you know, if I had to choose between operating or not operating, I would choose not to operate on this gentleman.
Okay.
I would also add on the axial, it appears to me that the nasal bones are eroded on both sides, and we've used bilateral Lynch incisions that's connected like a letter H. You can expose that nasal defect where you may need to reconstruct the nasal bones as well after you resect it.
Okay.
Jim, why, if you mean while doing an open craniofacial or endonasal plus a Lynch, you mean?
Yeah, I guess you could do if you don't do an open craniofacial
Right.
Webb Ferguson, then you can do an endonasal plus the H incision.
Right.
So, Jacques and Jim, you were leaning towards a surgery. Zuka, less so. Franco, thoughts? Anything?
Well, I think, yeah, this is it's going to be tough. You know, the option is to offer an operation to him or to simply palliatively radiate him. You know, his survival is poor. Once he's failed induction chemo, you know, his survival drops into the 25 to 30% range. I think resecting this is going to require a right-sided orbitectomy. I think there's going to be a need to have an upper rhinectomy. You are going to lose some of the forehead bone because I think the anterior table of the frontal sinus is involved. So it's a pretty massive resection. He'd clearly need free flap reconstruction for it. And he would have a fairly high risk of recurrence after surgery. So I think that has to be a very frank discussion. The other thing you can do is just have them go straight to chemorads at this point and see what that does. Because we have had some patients who have been like this, failed induction, and we've moved them directly to curative dosing radiation therapy with platinum, and have actually in a few patients have been able to get them back into being a better operative candidate. But still, it's a poor outcome. Surgery would be massive. Likelihood of survival from that surgery is probably in the neighborhood of 25% 5-year.
Franco, is there reason based on the data that we have to differentiate, to split the failing induction into the ones that never respond versus perhaps like this patient where it seems there was apparently some initial response and then it got out of control? I wonder. You don't think we have any basis to differentiate?
We don't have the data to make that jump.
Well, but what you practically do in some of those tumors is that you kill the most chemosensitive cells and you select the most chemoresistant cells, and then instead of having a certain percent of
Right.
your cancer cells resisting to chemo, now the entire tumor has become like resistant to induction chemo. So does it make it any more aggressive? Who knows? But you certainly select the more treatment resistant cells.
So I think these are all excellent points as shown. This is not an easy situation, and regardless is going to require extensive counseling to the patient. We did opt for surgery. The big concern for me as a neurosurgeon was the superior extent. I've become certainly more comfortable after my fellowship, actually working a lot with atomization, working through the face as opposed to always wanting to see things from above. But this was one of those situations where I thought it was a little bit too superior. So we did a combined anterior craniofacial and bicoronal approach down so that we would feel comfortable, particularly with the margins along the superior sagittal sinus, as well as some of the bony reconstruction. And to emphasize a point that has been hammered down, this is this is a team of everybody. Eric Lamar from Head Neck Surgery, Jamie Koo, Franco, who you may have remembered, did her fellowship a few years ago, because everybody's job is equally important, and fortunately, everybody thought that somebody else's job was harder. So that's when your team works. Franco has made me question my usage of lumbar drain here, so I might look into that. But you can see what we did here with reconstruction of the free flap. again, so this is kind of what it looks like intraoperatively and some of the major challenges. Just some of the points here. Huge dural defect, right? A 7x6 dural defect. These are pictures that I got from João Paulo Almeida, who's my fellow who did this surgery with me. But you can see huge dural defect that really requires a multi-layer reconstruction. So we did, you know, a big piece of fascia lata sewn in. You can't always get it watertight, but certainly stopping the big wave of CSF and even getting something smaller is helpful. We see the pericranial flap, the area of bone that was involved as well. We actually took a piece of the craniotomy here and just used it to reconstruct the, you know, the frontal bone defect, and then reconstructed this with mesh. And then of course, the ALT free flap to reconstruct. We can see here the patient's course. This is not benign. Again, why you really require an even bigger team outside the OR. You know, the patient had significant delirium, did not have neurological complications, but the ICU care, you know, really critical. This is what the post-operative scan looked like, but more importantly, at least by frozens, it's not final margins, of course, but at least by frozen, the frozen margins that we had intraoperatively were negative. We only did it about a little over a week and a half ago. So I don't have any of the further follow-up on this patient yet. But that was just our thought process with this case. And I'm happy to, you know, for any final comments from the speakers.
I think it was very reasonable.
Great. No, yeah, well done. I mean, you know, time will tell, I guess, but
Sure.
I agree with the.
Yeah, so just not to belabor, unresectable does not mean that you cannot operate. Unresectable means that surgery is not likely to help the patient. And, you know, we know once the dural barrier is crossed from a tumor coming from the sinonasal cavity, the risk of distant metastasis goes up. The risk of spread in the intracranial cavity in the subarachnoid space goes up. So it's not so much that we cannot technically do the surgery. Obviously, you know, two key things in that particular case that you presented. One, you know, you were able to get the patient through this major resection without potentially having a major life-threatening complication. The second next step is going to be getting the patient healed fast enough to get timely adjuvant radiation, because surgery alone is not likely to cure the patient. So the next thing is going to be to get the patient in the best possible shape to get adjuvant radiation soon enough, and then wait and see.
Gentlemen, I have only two questions from the audience that since you've been covering some of the questions, so let me pose a couple of questions for you. First, from Shiazor Onya, who would like to know, what would you advise as a practical guide for determining which cases should be resected via open or which ones via endoscopic? I understand we all agree that this is not endoscopic versus open, but can we give our maybe younger audience some general guidelines, I mean, that may or may not have filtered through our conversation? When should they do endo? When should they do open? Or should they just consider always both? Or Zuka, how could you answer this question?
So there are a few principles that I like to stick by. And, you know, if you are able to resect a tumor, getting negative margins using an endoscope, that would be a good case to resect endoscopically. You, of course, need to be able to reconstruct as well, because it's not just taking the tumor out. Some of the challenges for endoscopic reach and manipulation and getting negative margins are the extent of the involvement of the posterior table of the frontal sinus, and the case that Pablo presented is a clear illustration of this. The other challenging areas, both to reach and to reconstruct, are the orbital roof in a coronal plane lateral to the superior rectus. Once you have involvement of the dura lateral to the superior rectus, even if you work from the opposite nostril, it becomes very hard to appropriately clear the margins and do the reconstruction. So those are two simple rules that I give. The third one is there are some very highly vascular tumors that even though you could resect endoscopically, you end up losing a lot of blood and it ends up being a mess. Sometimes even for a small tumor, but a very vascular one, an open approach may be just easier to control the blood vessels and to get the tumor out. This is my easy answer to the question you asked.
I work with Suzuka all the time and I completely agree with his answer. Anybody wants to add anything to that?
Just to add the issue of the margins, which is a foreign concept for most of the time for neurosurgeons, you have to be comfortable taking the margins, right? Which it's not like, oh, I'm just going to take a little bite out of this. No, you actually have to really feel comfortable taking the margins and potentially going even further when you get positive margins. And so that has to be taken into account. And I think that as the endoscopic experience increases in your practice, your comfort level may change with that. But certainly, no matter where you are at, you have to assume that you're going to maybe even go farther. As Suzuka pointed out, there's certain pathologies, you know, which really like going further than what appears on the MRI scan, and that's where your pathology also is critical in that.
And I think involvement of the skin is a contraindication to endoscopic as well.
Okay, and next question from Antoinette Reyes, who actually is in her undergrad studies. Congratulations, Antoinette, and good luck in your continuing studies. She'd like to ask actually two questions. One of them is, what are some common screening tests that individuals should take to check for sinonasal cancer? Suzuka, I suppose I can probably predict your answer, but would it be fair to say that because it's such a rare disease, screening makes no sense, or what? How would you answer?
So the alarming symptoms and signs for sinonasal cancer are persistent unilateral nasal obstruction with nosebleeds. Those are common signs of sinonasal cancers in adults. Unilateral otitis media with effusion when the eustachian tube is clogged is a concerning sign. And you know, by screening, you mean an endoscopic exam for the nose. So you would need a nasal endoscopy every single time you see an adult with a persistent effusion in the middle ear. Obviously, if you have, you know, headaches or diplopia, but then we're talking about more advanced sinonasal tumors. So the worrisome symptoms would be persistent unilateral nasal obstruction with epistaxis, unilateral otitis media with effusion, and the screening test for sinonasal cancers are either a nasal endoscopy in clinic or imaging studies.
But maybe you want to clarify also that I don't know if she has in mind screening like we would screen for breast cancer in women, totally asymptomatic patients, you know.
So there is no recommended routine screening for sinonasal cancers. There are some professionals who are at higher risk for developing sinonasal cancers: leather workers, tanners, woodworkers exposed to professional you know, dusts and chemical fumes are at higher risk. We do not have any recommendations to systematically screen any patient population routinely for sinonasal cancer. If patients have a certain Southeast Asian descent and they have a high incidence of nasopharyngeal cancer in their family, there are some blood tests that could be used for routine screening for nasopharyngeal cancer, but not so much nasal cancer.
The second part of her question has to do with what has happened to complication rates and infections over the years. Franco, I mean, your data has shown a significant drop in complication rates, correct?
From the 90s on, our risk of infection has been very low.
Yeah.
I think with the routine use and application of perioperative antibiotics, it is just almost unheard of, infection-wise. And I think our complication rates have decreased. Over the last 30 years, our ICU care is better, our perioperative care is better. All those things are giving us healthier patients who, even if they're sick, we get them through these things. Some changes in my practice, omitting the use of the lumbar spinal drain has made it, at least for open craniofacial. We haven't really analyzed the endoscopic stuff yet. But there's no question that once we stopped using spinal drainage, our complication rates really went down with our surgeries.
Okay, well, gentlemen, this has any other open questions to each other, panelists, speakers? If not,
I have one quick question, Jacques.
sure.
On the subject of chasing that negative margin, would any of the panelists, if it's going to affect quality of life, let's say you're near a critical structure, I don't know, cranial nerve or optic nerve or something important, would you leave that little thing behind to, improve that person's quality of life? And we have some cases, of that where we've left, just a little microscopic residual, just 'cause we don't want to, hurt the patient. How do you make that decision intraoperatively?
So,
Go ahead, Franco.
yeah, I can tell you that the only time, the only thing we don't do is take out the carotid artery, because our outcomes from that maneuver have been terrible. And they don't die because we take out the carotid artery, they die from their biology of their disease. So I don't think that's a valid, for high-grade malignancy, high-grade, especially epithelial malignancy. I would take out any other structure to cure the patient for that subgroup. Now, we also, when we looked at our sarcomas and looked at it from high-grade sarcoma and low-grade sarcoma, the high-grade sarcomas, if you leave disease behind, they're going to die, right? So you got to be very aggressive, and those patients, if they survive their disease, survive long-term. They have very good survival. We made the decision in some low-grade sarcomas to do exactly what you said, Jim, is to leave some disease behind to, maximize their quality of life. And we don't have the data because we didn't have the prospective evaluation of quality of life over many years. But I think personally that we did keep their quality of life high, but we had 100% recurrence rate. Okay.
So for those sarcomas, you have the benefit of adding radiation that could help you control the disease. But for epithelial neoplasms of the sinonasal cavity, there's no question that you'd be helping the patient more by achieving negative margin. And usually when it takes resecting a critical structure, we are dealing with T4B disease. And that's why, I'd rather not operate on a patient and leave a little bit of cancer behind, because of the study that I showed that says, grossly positive margins, debulking surgery, or microscopically positive margins all do equally poorly. If you really want to help a patient with a sinonasal epithelial tumor with surgery first, your goal should be a negative margin. And this goes back to the question I was asked earlier about, would you take out an eye? Yes, if the last positive margin requires orbital exenteration, the patient has to make that choice. If you leave positive disease in a functioning eye, the cancer is going to take the eye function, and the cancer is going to make the patient much more miserable than your orbital exenteration. If you leave disease on a cranial nerve, the disease is going to take away the function of the cranial nerve, add to it pain, and decrease survival. So I would have a much lower threshold to sacrifice a structure. I completely agree with the carotid artery. The only exception I could think of would be adenoid cystic carcinoma in a young, extremely healthy patient. Other than this, we would not sacrifice the carotid.
You know, not an uncommon scenario regarding your question, Jim, is kind of the margins of the cavernous sinus, or even frank cavernous sinus. You know, you chase V2, you keep chopping up at V2, positive, positive, and then you don't, on MRI, it had no disease, yet frozen is positive. So the question, and I've done this, I've come back, depending on the age of patients, and I'm curious what Franco and the rest of you do. Do you come back then, Franco, and do whatever it takes, a transcranial cavernous sinus partial exenteration without removing the carotid? In the, you know what I'm saying? In a scenario like this.
Yeah, I think, especially for adenoid cystic carcinoma, when we know it's that pathology, we're prepared at surgery to resect the anterolateral cavernous sinus. You know, and you can do that transfacially. You don't have to open the head for that.
No, sorry to interrupt you. I mean, but you know, sometimes the pathologist cannot commit. You know, when you know the pathology a few days later, do you come back?
That's complex. So it would have to, the pathology would have to be taken into account. Yeah. And the subcategorization of the pathology. For example, one adenoid cystic is not the same as another adenoid cystic. You know, and I think.
No, and also, was the frozen, you know, the margin, let's say it was red negative at frozen, and then it comes back a few days later, guess what? It was positive or something like that.
Again, the nuances of the pathology are really important, and what you think you could achieve by going back. So, I mean, if we're down to the point of a small cluster of adenoid cystic cells in the stump of the nerve you resected, we probably manage that with radiation therapy, and I probably would not go back. If I left gross disease behind, that I didn't realize I left gross disease behind, and the pathology was appropriate for that decision, then yes, I will go back.
Anything else, gentlemen? Otherwise, this was a fantastic session. Franco, I'd like to thank you for taking time out of your vacation time in Texas to do this. Jim, Pablo, Albert had to go to the OR. Zuka, fantastic. Have a good evening, everybody. Thank you so much, and thanks for the audience.
Thank you.
Thank you, John.
Thank you.